Definition and epidemiology. Sexual violence occurs all over the world. Terms like sexual violence, rape, and sexual abuse are commonly used synonymously. However, they describe many different acts. The World Health Organization (WHO) defines sexual violence as any sexual act, attempt to obtain a sexual act, unwanted sexual comments, unwanted sexual advances, or acts to traffic or otherwise directed against a person's sexuality using coercion by any person, regardless of their relationship to the victim, in any setting, including but not limited to home and work. It should be kept in mind that medical, social, and legal definitions of sexual violence vary between and within countries. Rape is typically defined as a physical violence against the body with coerced penetration of the vulva, anus, or oral cavity. During commission of this crime, the perpetrator humiliates and typically threatens the victim either verbally or with a weapon. Estimates of the number of sexual assault victims vary. Comparative reanalysis of the prevalence of violence against women and health impact data in Europe from Schroetel et al. Indicates that 1 in 3 to 5 women have experienced physical force against the body perpetrated by their current or previous sexual partner. Of the European women who were questioned, 6 to 12% were victims of sexual violence committed by their current or previous partner. According to 2003 WHO guidelines, between 6 to 46% of women have experienced attempted or completed forced sex by an intimate partner or ex-partner at some time in their lives. It was found that 7 to 36% of girls and 3 to 29% of boys have suffered sexual abuse. Victims of rape are also elderly women, men, and institutionalized disabled persons. The estimated number of unreported cases among all groups cannot be specified but is presumably high. One of the causes is the varying definition of sexual abuse among countries and therefore data cannot be consolidated. Moreover, not all countries have a reporting system for sexual abuse. Sexual abuse of children and adolescents can include a wide range of sexual activities with the direct or indirect involvement of the victim, including intercourse with the victim, touching the victim's genitalia, and exposing the victim to pornography. The child or adolescent does not fully comprehend the acts and thus cannot give informed consent. Again, definitions of this crime vary among different countries. In the case of rape, perpetrators are typically men, although women sometimes commit this crime. In case of child sexual abuse, perpetrators are frequently men, and an increasing number of perpetrators are adolescents and boys. Because child abuse is typically committed by family members, the perpetrator is often the victim's father, stepfather, uncle, grandfather, or brother. Heading: Risk Factors. Many factors increase the risk that someone will be raped. Although every person could be raped potentially, some individuals are more vulnerable than the others. These include single unaccompanied women, physically and mentally disabled persons, individuals with drug or alcohol problems, and victims of war. There are likewise a number of risk factors that make children or adolescents more vulnerable to sexual abuse. These include being female, having a physical or mental disability, coming from a broken home, having parents who are themselves abused, and having parents with drug or alcohol problems. Heading: Forms of sexual assault. Heading: Rape. The type of sexual assault depends on the relationship between the perpetrator and the victim and on the perpetrator's motive. The following are examples of situations in which rape can occur. 1. Rape by an intimate partner. 2. Rape within dating relationship. 3. Rape by a stranger. 4. Rape of women of all ages but especially elderly women. 5. Rape of disabled persons. 6. Rape within marriage. 7. Rape during armed conflict. Often the motive of the perpetrator is not sexual desire but the need to demonstrate power and display rage. Such violent assaults typically occur between persons who know each other, and so it is often jealousy, fear of dissolution of the relationship, or unrequited love that leads to sexual assault. Next heading, child sexual abuse. Child sexual abuse can be hands-on or hands-off. Hands-on offences are sexual acts with physical contact such as 1. Touching or stroking the body or genitalia. 2. Sexual penetration of the child's mouth, vagina or anus. 3. Inserting objects in the child's vagina or anus. 4. Masturbating in front of the child. Hands-off offences are sexual acts without physical contact such as the production of a porno film with a child, exhibitionism, verbal sexual violence, or watching porno films with the child. Sexual violence can occur in virtual environments through cyberbullying. Cyberbullying occurs within a community or peer group when sexual information about a victim is distributed using digital means. This information, typically pictures, can spread very quickly through SMS messages, MMS messages, emails, chat rooms, and websites. Online chat rooms provide men with an opportunity to prey on underage girls and can be a great danger. Older men who stalk these chat rooms describe themselves as younger than they are or of the same age as the child or adolescent to gain the victim's confidence. The purpose of this cyber grooming is to manipulate the victim into meeting the perpetrator face to face. This is happening in UK. Next, examination is the heading. Examination of adults. Next heading, general aspects. Another heading. Forensic and clinical examination should compile a complete record of injuries and all available evidence while being cognizant of the victim's physical and emotional needs. When interviewing or examining the victim, the examiner should be patient and open, but also objective and neutral. The top priority of an examination should be to protect the victim from further trauma. This requires the support of both the social support network and health and medical care systems. These systems, however, vary greatly among countries and do not always provide the medical and emotional support needed by the sexual assault victims. Next heading, physical and genital examination. Before examining a victim's body, the examiner must know the victim's account of the crime in detail to ensure that an account, the injuries and the evidence are consistent with each other. Some important questions to ask when interviewing the victim include 1. Who was the perpetrator? 2. When did the rape take place to determine the interval between the rape and the examination? 3. Where did the sexual assault take place? Example, on the floor of a room, in the bed, outdoors, etc. 4. What is the kind of violence, including bites, kisses, licking, which occurred? 5. Did the victim resist? 6. Did ejaculation occur? If so, where? 7. Were the persons involved under the influence of drugs or alcohol? 8. Did the victim clean her or his body after the assault occurred? And if so, what were the methods used? With regard to the rape of a woman, special questions about contraception and communicable diseases complete the analysis. Depending on the interval between the sexual assault and examination, the morning after pill should be dispensed. Blood tested for HIV and hepatitis. Swabs taken to test for venereal diseases. Sometimes when a female victim was raped by a stranger and had sexual intercourse with her consensual intimate partner, a short time before or after the sexual assault, different traces of sperms or a mixture could be found in the DNA. The anamnesis should therefore include details about the last voluntary sexual intercourse. A careful anamnesis also includes questions about victims' gynec history. Typical signs of extragenital injuries. That is the table number 1. Typical signs of extragenital injuries are neck, that is strangulation, petechiae and love bites. Second, hematoma at the inner thighs. Third, scratches at the buttocks and breasts. 4, bites at the breasts. 5, fingerprints on the upper and lower arms. Generally, the physical examination should involve all parts of the body. To help the victim, examiner should ensure that the examination is done by a person of the same sex. If this is not possible, the examiner should have an assistant of the same sex nearby. Care must be taken to ensure that the victim does not undress completely, but only partially, to enable examination of one naked part of the body after the other. The injuries should be documented in words and in pictures. We have already seen the typical extragenital injuries. After the extragenital examination, a genital examination should occur. Ideally, the genital examination should be performed by a forensic expert in cooperation with a gynecologist. The examination should take place on the gynecological chair. Only persons with a physical disability should be examined on the examination couch. For inspection of the external genitalia, the labia majora and minora will be spread and then pulled forward and down with the fingers. Separation and traction, that is called. The inspection of the hymen occurs in this position. Normally, the hymen can be brushed from the inside to the outside with a cotton swab. An investigation with a speculum is necessary only if there is a hemorrhage out of the vaginal canal or there are foreign objects inside. Use of a speculum may create difficulties because the speculum blocks the view of the hymen, preventing an existing injury from being seen. The speculum itself may injure the hymen, making it impossible to distinguish between an injury caused by the sexual intercourse or an injury caused by the speculum during the examination. The following are typical genital injuries. 1. Defloration of the hymen. 2. Tears of the hymen or vaginal vestibule. 3. Scratches and tears at the labia. However, victims typically do not have genital injuries after a sexual assault. During the examination on the gynecological chair, genital swabs from the vaginal canal or portio can be taken, as well as swabs to determine the presence of venereal disease. During the examination of the vaginal canal, accumulation of secretions, injuries of the vaginal canal or the portio uteri, fresh bleeding and foreign objects can be discovered. If there are hemorrhaging injuries, an operation should follow immediately. Using an abdominal ultrasound and or a vaginal ultrasound examination, injuries or bleeding inside the abdomen can be excluded. If necessary, other diagnostic or surgical measures can be taken. The inspection of the anus happens in the same position as the inspection of the vagina. Though the buttocks are spread, apart for a certain time, during which the anal sphincter can dilate, allowing the anus and the anal canal to be inspected. The anal folds, pigmentation, possible scars, injuries and bleeding should be examined. If there are major psychological problems because of the vaginal inspection or because of pain, conducting an examination under anesthesia should be discussed with the victim. If possible, the examination should be done without anesthesia, as it can change findings of the vagina or anus because of relaxation of the muscles. If necessary, blood and urine should be tested for alcohol or drugs, both of the victim and when possible the perpetrator. After a report is filed, the police can secure evidence from the perpetrator. Especially after a rape, the examiner should be aware that swabs of the penis can be used to search for biologically female particles in the DNA analysis. Table 2. Changes of the hymen depending on the influence of hormones. The development of the hymen differs in individuals. Therefore, hormone dependent hymen configuration change has a flowing time parameter. On hormone dependent developmental changes of hymen and age of life. Stage of newborn less than third week, hormone free period, that is unestrogenized state of the pre-pubertal years, third week to 8th year. Pre-pubertal period is more than equal to 8th year. Pubertal period, that is greater than menstrual period, that is after the menstrual period. Next, securing evidence. After the sexual assault, various bits of evidence can remain on the body of a victim, including sperm and seminal fluid, saliva, and skin particles. This is the evidence that can be secured most frequently. Combing out pubic hair is also considered a general measure to secure traces. To secure sperm or seminal fluid, the examiner has to know whether and where ejaculation took place. It is not self-evident that ejaculation occurred during the sexual assault. To secure sperm or seminal fluid, the examiner must use DNA-free swabs with or without a special transport medium. If ejaculation occurred in the oral cavity, the swabs should be brushed against the cheek pouches. With regard to the anamnesis of the victim, vaginal swabs are mainly taken from the posterior vaginal fornices and the introitus vaginae. Swabs of the anus should be secured with caution, as they can be painful for securing sperm and seminal fluid. Several cotton swabs, ideally 3 to 4, should be used at once. The period during which sperm can be detected in the vagina is 4 days, though usually this period is shorter for microscopy, perhaps 48 to 50 hours. If the sperms cannot be detected under microscope, the Y chromosomal marker on the cotton swab can be investigated. The period during which sperms can be detected in the oral cavity and in the anus is shorter. It is 12 to 24 hours in practice, however. They are rarely found there. After an ejaculation in the oral cavity or in the anus, victims frequently clean their mouth or anus, destroying the evidence. If no sperm are found, the perpetrator may have an azoospermia or have been sterilized. In this case, the prostate-specific antigen or the prostatic acid phosphatase can be investigated through immunochromatographic tests. If the tests are positive, a DNA analysis may be carried out. Table 3. A few normal variants of the hymen. Normal variants of the hymen are 1. Annular hymen, 2. Crescent-shaped hymen, 3rd. Septated hymen, 4th. Cribriform hymen, 5. Microperforated hymen, 6. Imperforate hymen, 7. Atresia of the hymen. Next heading, examination of children and adolescents. Heading, general aspects. The well-being and health of a child or adolescent is the top priority during an examination. The examination should be conducted in a gentle manner and with patience. A victim should never be forced to undergo an examination. When examining a child or adolescent, the presence of a parent or guardian is necessary. It is a must. The younger child, the more important is the attendance. The younger the child, the more important is the attendance of a parent or a guardian. The examiner should be aware that person accompanying the child could himself or herself be involved in the sexual abuse. The examiner should be qualified in how to examine the victim and how to interpret the findings. He or she should be aware of the hormonal influences and therefore of the development of the genitalia, especially the hymen. That is table 2. We have already read. Table 2 are annular hymen, crescent-shaped hymen, septated hymen, cribriform hymen, microperforated hymen, imperforate hymen, and atresia of the hymen. Their normal variants and endocrinology. Stage of newborn less than third week, hormone-free period third week to 8th year, pubertal period more than 8th year, pubertal period more than the menstrual period. Newborns have their mother's hormone in their body until perhaps the third week postpartum. After that, the hormone-free period begins. During this period, the hymen is transparent, thin, and prone to damage. From the 8th to 9th year, the child's own hormones, estrogen, begin to influence the genitalia, prepubertal and pubertal period. The hymen thickens, wrinkles, and becomes stretchable. From the beginning of these changes of the hymen, a vaginal penetration by a penis is possible, potentially without causing injuries. Getting a report of the crime is important, but the younger the child, the more difficult is the question. A toddler is suggestively influenced through questions. Therefore, it is often best to allow specially trained personnel to conduct the questioning. Heading: Physical and Genital Examination. The examination by an expert includes the inspection of the whole body and after that the genitalia. The inspection of the whole body should signal to the victim that the examiner is interested in the patient in his or her entirety and not only in the victim's genitalia, which will relax many young victims. The investigative technique depends on the age of the patient and also on the hormonal influence of girls. A toddler who is free of hormones can be examined while sitting on the lap of a parent or a guardian who can hold and spread the legs of the toddler. In this position, the labia majora and minora, the introitus, the hymen and anus can be inspected. The examination of an older girl in the hormone-free period can take place on the examination table, first in the supine position and after that in the so-called frog leg position. A girl in the prepubertal or pubertal period can be examined in the gynec chair. The inspection of the hymen of a girl in the hormone-free period has to be performed quickly and without causing pain. To ensure this, the labia have to be pulled forward and down, separation and traction with the fingers. By contrast, the hymen of a prepubertal or a pubertal girl is less sensitive to pain. In this case, a cotton swab can be used to display the hymen, facilitating inspection of the margin. An inspection of the hymen with the speculum is contraindicated, as is examination under sedation. A boy is to be examined on the examination bed in a lateral position while bending the hip joint and the knee joint. In this position, the buttocks can be spread and the anus inspected. The buttocks should be spread as long as possible to reach reflexive dilation of the anal sphincter. The penis is to be examined with regard to bleeding or other injuries, but the perpetuum should be withdrawn from the examiner or better by the boy himself. Heading: Securing the evidence. A fluid like semen is difficult to collect. Generally, children and adolescents come to be examined long after the assault. Commonly, months or years lie between the examination and sexual abuse. Literature describes the semen in the vagina of the girl in the hormone-free period is detectable only for 9 hours, up to 24 hours, but no longer. For the securing of saliva or skin particles, see earlier text. For interpreting the findings of the genital examination, especially of the hymen, the so-called Adams scheme, revision 2007, can be used. Next heading: Documentation. Independent of a report to the police, the anamnesis and all injuries should be documented in a standardized way. Generally, a documentation form can be used to simplify the process. This can also serve as an aid to memory at a legal proceeding later. The following are guidelines for filling out a documentation form. 1. Description of all injuries ought to be written down exactly, that is, characterize the color, form, margin, dimensions and exact location of the injuries. All injuries must be included. 2nd. The injuries should also be photographed. A picture should be taken as an overview and then injury photographed in detail with a scale. The photo should be taken at a right angle to the injury. If the photo is taken in an oblique projection to the injury itself may not be sufficiently visible. Next, the report of the victim is to be documented exactly and in depth. Sometimes it is important to quote verbatim the words or sentences of the victim. Some victims do not understand words like ejaculation or erection. The examiner should speak clearly and should explain the words when necessary. Next, securing traces requires correct procedure. The examiner may find in examination how to secure the traces in the documentation form. Generally, the traces should be dry and clean. Next, injuries and result of traces should be interpreted carefully. Next heading, case management. A team assembled from various medical disciplines is needed to support a victim quickly and professionally. Conferences is to be organized by the head of the team, most suitably the social health worker from the clinic. Depending upon the kind of sexual assault, some of the experts on the team have to meet for discussing the internal course of action. The modus operandi of the healthcare team depends not only on the kind of sexual assault but also on the health system. An expert who works in practice has to organize his healthcare system by himself. Here, the approach is different from that in a clinic. The doctor in practice has to organize the network system from outside and know who the contact persons are before a victim of sexual assault appears in his practice. In a clinic, contact persons of the network system are noted through the sexual health care system of the clinic itself. Generally, if the victim is an adult, the discussions regarding what to do after the examination is restricted to the examiner and the patient. The adult patient decides, for instance, whether or not to file a police report. The social worker can help the victim learn about the methods available to protect herself or himself from the perpetrator in future. If the victim is a child or an adolescent, the discussion and decisions also depend on who the perpetrator is. If the perpetrator is within the family, a social worker should decide whether a report should be filed with the police or whether it is sufficient to take the perpetrator out of the family. These decisions depend on the findings of the examination. The clearer these findings are, the clearer is the course of action to protect the child or adolescent. The rules and legislation pertaining to this differ among countries.